Welcome once again to the AIOS headquarters, and we have a very important speaker today, Professor Amod Gupta, and I would like to welcome him to the AIOS headquarters. Thank you, sir, for
Thank you.
Coming
it's
here.
It's a pleasure.
Thank you, sir.
Thank you so much.
And I would also like to welcome Dr. Shishir Narayan, who is a panelist for the session.
Thank you.
Thank you, Shishir, for coming.
Thank you very
It
much.
is indeed a privilege and a pleasure to introduce the speaker, who is a legend in ophthalmology in true sense, and any amount of words that we use to introduce him would actually fall short of what we have to say. Professor Amod Gupta is an emeritus professor at the Postgraduate Institute of Medical Education and Research, Chandigarh, India. He was the dean at the PGI from 2010 to 2014 and headed the Department of Ophthalmology at PGI from 1989 to 2015. He is the person who actually conceptualized and raised the Advanced Eye Center at the PGI Chandigarh in 2006, which is the state-of-the-art center in North India. He has been at the forefront of clinical research in ophthalmology in the field of retina and uveal diseases, and true doyen in ophthalmology. He has published more than 375 original research papers with a citation index which is unimaginable, which is close to 6,027. In 2003, he described a new entity, the tubercular serpiginous-like choroiditis, that is recognized all over the world in the early 90s. And he first also introduced the use of high technology in eye care in North India, and was among the first to start vitreoretinal surgery in the entire northwest India. He was also elected the president of Vitreoretinal Society of India, and was also the founder president of Uveitis Society of India. There is a huge list of honors and awards to his credit, and if I go through those, then we would probably finish the next half an hour doing that. He's got numerous awards such as the Dr. R.N. Mathur and P. Seva Reddy International Awards at the All India Ophthalmological Society, the Dr. V.R. Khanolkar Award by the National Academy of Medical Sciences, Vigyan Ratna by Punjab University, and above all, he was bestowed the Padma Shri in 2014, which is the 4th highest civilian award in India by the President of India. And I would now request Professor Amod Gupta to give his talk on approach to posterior uveitis. So we are really privileged and honored to have you here at the AIOS
Thank
headquarters.
you, Dr. Namrata Sharma, for introducing me to my friends. And this afternoon, I shall like to share with you my approach in evaluation of patients with posterior uveitis. I am sure you are all familiar with this Sun working classification of the anatomic classification of uveitis, and the posterior uveitis is the one where the inflammation is localized primarily in the retina or choroid or the retinal vessels or the optic nerve head. We also must realize that at times patients who develop pan-uveitis may present first time in the posterior segment. When we are evaluating a patient of posterior uveitis, which I am sure you are all familiar with the techniques of evaluation, you need to be able to describe the laterality of the disease, the course, whether it's acute, it's chronic, it's recurrent, are the lesions paucifocal or multifocal, what is the morphology of the lesions, what is the anatomical location of the inflammation, and above all, what's the immune status of the host. We can broadly categorize the inflammation in the posterior segment into 3 categories: the infectious, that include toxoplasma, acute retinal necrosis, and so on, or those inflammations which are associated with systemic disorders like tuberculosis, sarcoidosis, the weak edge disease, and so on. And then there is a set of posterior uveitis entities. We used to call them white dot syndromes, which I will be briefly touching upon. Now, I want to make a very sweeping statement here that retinitis is mostly infectious and choroiditis is mostly non-infectious. Why is it important to tell the difference on your clinical exam, whether it's retinitis or it is choroiditis? Will be evident from the example I am giving you. Here's a young lady who was treated as a case of choroiditis, and I am sure it's obvious to all that this is a patient of toxoplasma retinitis. And thinking that this was a choroiditis, the eye surgeon treated her intensively over the 8 or 9 months with corticosteroids, given periocular, intraocular and oral steroids, which led to a disaster. From a 6/9 visual acuity, she went down to almost counting finger close to face. On the other hand, when we treat patients of choroiditis, which are basically immune mediated, with antibiotics, you may have again a disastrous situation. Like in this patient who was diagnosed as tubercular choroiditis, was initiated on anti-TB drugs, and you can see how the lesion on anti-TB drugs alone, they progressed over the next several weeks, threatening her central vision. The surgeon didn't realize that this patient, the main mechanism of inflammation is immune mediated rather than the infection by the MTB. Now, how do we tell the difference on clinical exam? So, say like this patient, again I will take the example of toxoplasma retinitis. You would see localized vitreous reaction, inflammation overlying the patch of retinitis. The retinitis lesions are by and large opacification of the retina with indistinct borders, and the retinal vessels are obscured by the retinitis. When these lesions heal, they leave behind an atrophic thinning of the retina at that place. On the other hand, the choroiditis lesions might be multifocal, but what you would realize that they have the borders which are rather more distinct, as well as the overlying retinal vessels course over these lesions undisturbed, and there is no, by and large, no inflammation of these vessels. Coming back again to the same example of retinitis, I would like to show you the fluorescent angiographic characteristics of the retinitis lesion. The retinal vessels, as I said, coursing through the patch of, they get inflamed, and you can see here the staining of the vessel wall of the retinal vessels, and there is intense late hyperfluorescence of these retinitis lesions. On the other hand, when you look at the a patient with choroidal granuloma here, there is a serous detachment. When you do an angiogram in the early frames, you can see the hypofluorescence, and it becomes in the late frames hyperfluorescent, but it is not as intense as we saw in a case of retinitis. Now, we can also look at using the other imaging technologies like a structural OCT and see exactly the level of inflammation of the retina. Like in this patient of toxoplasma retinitis, there is a full thickness involvement, hyperreflectivity and thickening of the neurosensory retina, and as the lesions heal following treatment, you can see that the thickening of the retina and hyperreflectivity gradually comes down, leaving behind ultimately a scar. The other characteristic features on OCT are these clots of cells on the posterior hyaloid surface, which have been recently described, as well as the retrohyaloid deposit of these cells. So, if you have access to an OCT, a spectral domain OCT, you could be making a more confident diagnosis of a toxoplasma retinochoroiditis based on this. Moving on to a patient like here, he was a young man who had a renal transplant some years ago and came to us with sudden onset of floaters in both eyes, and what we found on examination is a number of these small infiltrates, retinitis lesions all over the fundus, specifically seen in the periphery. And while we were trying to deliberate what it possibly could be, within a matter of 3 days, the patient went on to develop these opacification, the tongue-shaped lesions in the periphery of the retina, which were progressing very rapidly circumferentially as well as towards the posterior pole. Now, you might in this kind of situation like to make a clinical diagnosis by and large that this is a patient of acute retinal necrosis, most often caused by the varicella zoster virus, or in some instances by the herpes simplex virus. You may like to do a PCR if you have the facility, but by and large people would make a clinical diagnosis. These patients require a very urgent interventions, and this is, if I can say, this is one of the emergencies that a retinal surgeon or a uveitis expert would face in his career, because a timely action could save these eyes. As you can see, the treatment with intravenous acyclovir and followed by oral course of acyclovir is very, very effective in these patients. In patients who suffer from HIV infection and AIDS, and they are totally immunocompromised, you may have the VZV infection, which leads to what we call a progressive outer retinal necrosis, and you can see this mud crack appearance. The retinal vessels are spared. There is a minimal inflammation in the vitreous cavity, and this is a blinding disease, rapidly progressive, and unless a timely diagnosis is made, these patients will quickly go to blindness. Patients of AIDS, if they develop herpes zoster or varicella infections, are very prone to develop progressive outer retinal necrosis. I am sure all of you are familiar with CMV retinitis lesions, commonly associated in these patients, hemorrhagic retinitis lesions with the perivascular infiltrates. There is occlusion of the retinal vessels here, and it's a slowly progressing disease and may affect the periphery, which progresses towards the posterior pole. We are seeing fewer patients these days because of the availability of the heart therapy in these patients, and the CMV count, the CD4 counts remain high, so CMV infection occurs only when the CD4 counts are less than 100. Some of the features of CMV retinitis, if you have access to an OCT, is the intraretinal edema. Note that there is no choroidal involvement in these patients with viral retinitis. Patients with, again, HIV infection, if they present with atypical infection of the retina, there may be more than one infection, and this particular patient, we found that she had not only VZV infection but as well as toxoplasma infection. So you must have if you know the immune status and the patient is immunocompromised, you must keep in mind more than one infections. Very often post rainy season, we have these vector-borne infections in different parts of the country, dengue being one of the commonest viral infection that we see, and the patients might be infected or affected in the eyes by way of these what look like cottonwool spots or the retinitis lesions. There may be variable amount of hemorrhages depending upon the thrombocytopenia that these patients have. I'll show you an example of a patient who's had dengue fever about 10 days back and then developed the ocular symptoms. When we did the angiogram, there wasn't much significant changes, very little fluorescence was seen in the late frames, but when we did the OCT angiography in these patients, we discovered the area of retinal opacification on cottonwool spots showed a significant capillary dropout in the superficial retinal plexus, and more significant was the involvement of the deep capillary plexus in these patients. Remember, these non-perfusion of the superficial and deep capillary plexus is irreversible damage, although the structural changes would recover over a period of time with intensive corticosteroid therapy. Like in this particular patient, you are seeing the conical lesion, foveolitis lesion is seen in patient with dengue fever, and over the next 6 weeks the lesions recover except the ischemic damage. Another infection we must keep in mind is syphilic, which is re-emerging in the Western world, specifically in patients, men having sex with men, and there is an increase in the incidence of syphilitic infection among the posterior uveitis. Nearly 5% of patients in tertiary syphilis would develop ocular changes, and one must have high index of suspicion, specifically the uveitis, which could mimic anterior, intermediate, posterior or pan-uveitis, and like here is presenting as pinpoint retinitis lesions here in both the eyes, and there is some kind of disc edema here and venous congestion. When we do the angiogram, we find there is a disc swelling, there is staining of the vessel walls, there is a significant cystoid macular edema as well. The patients with those who have HIV and syphilis co-infections, the higher titers also present with severer inflammations. Now, why we need to keep this in mind, because this can be very elegantly treated with intravenous benzyl penicillin. They need to be treated as tertiary syphilis, and here we have the same example here. You can see how within a matter of 2 weeks the lesions have very elegantly resolved. Patients who remain undiagnosed or untreated would present as chronic posterior uveitis, and specifically I would like to highlight this leopard skin appearance. If you see this kind of appearance on fluorescent angiography, it's very likely that the patient may have a syphilitic posterior uveitis. In these patients, serological tests are diagnostic, and we need to do both the VDRL, which is a non-specific, as well as the RPR and specific TPHA should be ordered. The reason being that in patients with HIV infection, the non-specific tests like the VDRL may be negative. Now, coming to the second part of my talk, the inflammation, the choroid. These granulomas are most often caused by sarcoidosis or tuberculosis. Here is an example of a patient who is showing the sarcoid granuloma. That you would realize here, unlike the retinitis lesions, there is hardly any vitreous reaction. There is a minimum vitreous reaction overlying these multifocal. They may be, unless you have a high index suspicion, you might miss some of these lesions which are very subtle. And on angiogram, you would see that again the lesions in the initial frames, the dye transit, very little hypofluorescence, very subtle lesions, and on late frames you are seeing only the disc staining as well as cystoid macular edema, but the lesions per se are staining very little. Another example of a patient with sarcoidosis, you can see the disc swelling here, very subtle venous congestion, multifocal lesions as you can see here. Now, in these patients, we like to do a simultaneous fluorescein and ICG. That would reveal the fluorescein to reveal the disc changes as well as the health of the retinal vessels, and the ICG to reveal these multifocal choroidal lesions as we can see here. And in the late frames, it becomes evident that there is a staining of the disc on fluorescein, as well as you can see the persistence hypofluorescence of the choroidal granuloma. Now, sarcoid granulomas are very, very sensitive to corticosteroids, and you can see the resolution, and you can see the resolution of the disc edema. The venous caliber has returned normal, and those lesions have practically disappeared, which you can confirm on fluorescein and ICG changes here, and the disc edema has disappeared following treatment with corticosteroid therapy, and so have the lesions. Now, if you do not wish to do the angiography time and again, you could use OCT very effectively. Like here is the patient with sarcoid granuloma, and this is on ICG, hypofluorescent, hypocynescent, and on OCT simultaneously. You can see there is a hyperreflective mass lesion, which is a full thickness sarcoid choroidal granuloma. And notice the elevation of the RPE, which is typically seen in patients with choroidal granuloma. You move the cursor and you find that passing through the line scan, passing through the center of the fovea shows that there is a cystoid macular edema. Now, when you want to monitor it, you can do it because there is a point-to-point correspondence when you take on a repeat visit. Like here is the choroidal granuloma. We want to follow it up and see this is the granuloma hyperreflective lesion here, and when you follow it up following treatment, you find that this granuloma has at the same spot we can exactly corresponding point we see the granuloma has disappeared. Now, how do we differentiate choroidal granulomas due to sarcoidosis from tuberculosis? Now, tubercular granulomas may be associated with little more exudation and commonly develop CNV, or what we call retinal angiomatous proliferans or RAP lesions, as you can see here. So, the clue might be in the presence of tiny intraretinal hemorrhage. If you see an hemorrhage, suspect tuberculosis, and you can see this RAP lesion is very elegantly demonstrated on the fluorescent angiogram here. In patients with sarcoid, you would also, if you are careful on slit lamp exam, you might see some of these granulomas sitting in the periphery of the cornea, and you can see them. They are lying in the inferior angle. So gonioscopy is a great tool to pick up these granulomas, which are typically seen in patients with sarcoidosis. A little bit of systemic examination also does help. Like here is a scar which biopsy revealed that was a sarcoid. This is a lupus pernio in a patient with sarcoidosis, and it does no harm to look at the legs and feet and the face of the patient to look at some of the clues from systemic examination, like erythema nodosum here, and in patients with acute sarcoidosis you might see. On X-ray chest is another very good tool to pick up this hilar lymphnopathy. My physician used to describe them as large lymph nodes which look like potatoes, and as you can see here on CT scan, you are seeing a large hilar gland here, paratracheal, compared to the glands that we see in tuberculosis, which are conglomerate, which are matted, as we used to call them. They are like can be clinically, they can be on CT scan, can be differentiated. Furthermore, these patients with choroidal granulomas could be associated vasculitis, as you can see here in this particular patient. In these patients, you may like to do, besides the X-ray chest or CT, HR, CT, you may like to do, if you have the facility of PCR, which might show the presence of the MTB genome in the ocular fluids, and this substantiates your diagnosis. Also, be aware that these patients, when they are put on anti-TB drugs and you give them inadequate corticosteroid therapy, as I said earlier, the reaction is by and large immune mediated, so they have to be given an adequate coverage of oral corticosteroids. If you do not give them oral corticosteroids in adequate dosage, you might see what we call as paradoxical worsening, and the patient's vision goes down immediately after starting the anti-TB drugs. In patients with sarcoidosis, you might come across patients who have nodular peripheral uveitis, which will become very evident on fluorescent angiography by focal staining, here nodular staining of the vessel walls as a pointer, and sometimes you might see these macroaneurysms, which are so classically seen in sarcoidosis. Only very, very rarely we have seen these kind of macroaneurysm occurring in patients with tuberculosis. Now, unlike the focal nature and candle wax dripping of the vasculitis that we see in patients with sarcoidosis, patients of vasculitis due to tuberculosis show extensive perivascular infiltrates. These are mostly occlusive vasculitis. There were a lot of retinal hemorrhages, as you can see here, and when you do a fluorescent angiography, you see extensive areas of capillary non-perfusion and the vessel leakage which are inflamed. In these kind of patients, you would like to do a tuberculin skin test or a Montos test and a contrast enhanced CT chest, and if available, easily accessible, you might like to go a step further and do a cytopathology examination. Like in this patient, it did reveal epithelioid cell granuloma with necrosis suggestive of tuberculosis. In that event, you can start these patients very confidently on anti-tubercular treatment as well as corticosteroids. Again, you can see the extensive perivascular infiltrates with the areas of choroiditis, and when you do this angiogram, again you find this perivascular staining as well as the disc staining in this patient. When the vasculitis, TB vasculitis heals, it leaves behind what we call pipe stem sheathing, because these are occlusive vasculitis. There is a non-perfusion here, and these are reed-like thin sheathed vessels that are left behind. I'll just like to share with you one of these patients who presented to us with vitreous hemorrhage, underwent partial vitreous surgery. He recovered 6/6 vision. At this point, he had no evidence of tuberculosis that we could detect, and he was allowed to go home. He returned 4 years later, and now with fresh symptoms, and he had multifocal choroiditis lesions as well as vasculitis, and you can see on angiogram an extensive non-perfusion. We did an axillary lymph node biopsy, and this was positive for tubercular granuloma and stain was positive for AFB. Finally, I would like to share briefly these lesions, what we call pattern recognition posterior uveitis. We in the past used to call them white dot syndromes. These are the inflammations of the retinal choroid, which we are still not sure what leads to these inflammations. And I would like to share the tubercular serpiginous like choroiditis, something that we described almost 15 years ago, affecting the young people who are otherwise healthy, have vitreous inflammation, and the lesions are sparing, very often sparing the juxtapapillary, the choroid. The lesions, they are multifocal, and they heal centrally and they expand centrifugal with the active edges, and they become coalescent and large, and you can see here the healing and the active edges. When these heal, these lesions leave behind variable and obviously exuberant pigmentary changes. These patients can also be, we can do a fundus autofluorescence to look for activity on fluorescent angiography. Of course, these lesions, active lesions, show hypofluorescence. The areas which have healed show central mixed fluorescence, transmission fluorescence, and the active lesions, they show a late fluorescence and staining of the edges of these lesions. When you wish to monitor these patients for response to your treatment, which includes corticosteroids and if there is evidence of tuberculosis, anti-TB drugs, the best form of non-invasively follow them up is the using fundus autofluorescence imaging, like here in this particular patient. You can see that clinically it's very difficult to comment whether this lesion is active or inactive, but when you do an angiogram fundus autofluorescence, you would see that these hyper autofluorescence lesions denote very active lesion. When you follow them up over a course of time, you would see these hyper autofluorescence become gradually hypo autofluorescence, and over a period of time these lesions heal eventually. Multiple evanescent white dot syndrome again is not very commonly seen in our population, but is characterized by young myopic females who present with floaters and blurring of vision, and you would have characteristic granular lesion in the fundus, and they will show by and large paramacular lesion and a disc swelling. So these are the three characteristics, and these are sheath like. When you do an angiogram, they have wreath like pattern to the to these lesions. They resolve spontaneously and they don't need any active intervention. The other white dot syndrome, which is again not very common in our population, is acute posterior multifocal placoid pigment epitheliopathy, or APMPPE, which was first described by Dongas in 1968, characterized by bilateral creamy placoid lesions. The OCT is highly characteristic as affects the choriocapillaries here. You can see the hyperreflectivity and obliteration of the choriocapillaries here and the outer retina, and these would resolve over a period of time with or without any treatment. The autofluorescence is highly characterized here in this patient with a central dark hypoautofluorescence surrounded by a ring of hyperautofluorescence. The other white dot entity which we see uncommonly is punctate inner choroidopathy. These are punched out lesions, and the first presentation would be when the patient present with blurring of vision due to the development of choroidal neovascular membrane in the fovea. These patients respond very nicely to the anti-VEGF agents, and they resolve, like here. The lesions are highly punched out, as you can see here, unlike the Mude's lesions. And on autofluorescence again, they share the same characteristic as in APMPPE, that is, there is a centrally dark and surrounded by a hyperfluorescent ring. As you can see, these lesions tend to enlarge. These are all healed lesions which tend to enlarge over a period of time, and these have, you can see here, the hypo lesions, they enlarge, the hyperfluorescence ring is disappearing, but these lesions are enlarging. The other white dot syndrome that we see again uncommonly is in female patients. We see the pan-uveitis with multifocal choroiditis lesions. They tend to develop juxtapapillary or subfoveal choroidal neovascular membrane with extensive fibrosis, and they require a very, very aggressive immunosuppressive therapy for keeping the inflammation under control. Again, the HLA A29 uveitis, as it's called, the birdshot choroidopathy, is uncommonly seen in our population and is marked by symmetric lesions in both the eyes, which are of variable discrete to confluent lesions which are seen radiating from the optic nerve head, and over a period of time the retina loses pigment. These patients again, it's a blinding disease, involves both the retina and the choroid, and they need to be treated very aggressively on immunosuppressive therapy. The one condition that we see very often in the posterior uvea is the VKH disease, which is essentially a pan-uveitis, but the initial presentation is in the posterior segment by way of blurring of vision, typically seen in young female patients, and you can see multifocal serous detachments and yellow-white lesions. The diagnosis is made by doing either a fluorescein or an ICG, which shows hypolesion becoming hyperfluorescent, and you might see the accumulation of dye in the subretinal space with multifocal pooling of the fluorescent dye, indicating the presence of multifocal serous detachments in these patients, as you can see it here. Now, these patients again need to be diagnosed, and you could do an ultrasonography to show a thickening of the choroid, or you can do an enhanced depth imaging of OCT to demonstrate diffuse thickening of the choroid. This is a blinding disease and has to be again very aggressively treated on intravenous methylprednisolone, followed by oral steroids and immunosuppressive therapy, be it is the methotrexate is avoided in females, particularly in the childbearing age group. So you might treat them with azathioprine, cyclosporine, or mycophenolate mofetil would be a drug of choice. If the immunosuppression is inadequate, these patients would go on to develop the loss of pigment, what we call sunset glow in the fundus, which is best avoided in these patients, because it shows that there is a continuation of subclinical inflammation in the eye. So I said the ultrasonography should be used to monitor these patients, or the OCT. The sunset glow fundus and other stigmata of VKH disease like poliosis, vitiligo are indicative that these patients have not been treated adequately. These patients may present initially also in recurrent stages of the VKH with either a single keratic precipitates here or multifocal pan-uveitis here. You can see granulomas in the iris as well as on the back of the cornea. And when you look at the fundus, you might see not only a red hue here, but also these are the lesions in the inferior periphery. These are very, very characteristic of VKH disease. Finally, a word about Behçet's disease, not uncommon, is commonly a pan-uveitis, bilateral, affects young people, is one of the most blinding diseases, may present with first with posterior segment with retinitis lesions, which can be transient actually. These are transient infiltrates, and 3 or 4 days later they may just disappear. It affects the disc, it affects the retinal vessel, the arterioles, and they require these days the majority of the people would treat them on biological therapy, if not starting with oral steroids and biological therapy would be the one, because it leads to invariably the blindness. To summarize, it is important to differentiate retinitis from choroiditis, because as I said, retinitis is by and large infectious, and I gave examples of toxoplasma and viral infections, including HSV and VZV, which are blinding disorders, or the vector-borne viral infection in the retina like dengue, chikungunya, and the West Nile fever and others, which could affect the vision if not treated in time. The anatomical location, so it's very critical to on your clinical exam, with the help of the multimodal imaging that we have, the fluorescein, the ICG, the structural OCT and the OCT angiography, to find out where exactly is the inflammation located, the morphology, the course, and you would have the diagnosis. Very often you would be able to make the diagnosis of posterior segment inflammations by your clinical exam, aided by the imaging technologies available in your clinic, and only occasionally you would need to do some of the tests like VDRL as a screening test, and TPHA more specific tests, and very targeted laboratory investigations for tuberculosis or sarcoidosis. Thank you very much, and I would welcome any questions and my panelists.
Good, thank you so much, sir, for that brilliant lecture. It was such a wealth of knowledge.
Thank you.
Which you can go through, 3,000 pages of a book and still not know what to look at. With so beautifully demonstrated pictographically. I would now request Dr. Rajesh Sinha to formally introduce our panelist, Dr. Shishir Narayan.
Well, I'm sorry, sir, I joined you late because I was stuck in my LASIK OT. Sorry for that. Sorry, Shishir. It was a wonderful talk. I was listening to you, sir. Definitely, as Dr. Namta told, it was a complete package, a concentrated thing taken out from so many loads of experience, of years that you have worked in the field of uvea. Along with Professor Gupta, we have Dr. Shishir Narayan, who is the panelist. He has graduated MBBS in 1990, and he was awarded DMA Best Medical Graduate Gold Medal. He obtained MS Ophthalmology from MAMC. He did Ocular Inflammation Fellowship under Dr. Biswas at Shankar Nethralaya, and then did VR Fellowship at Shankar Nethralaya under Dr. Badrinath. He completed his FRCS in 1997 and FRC Off in 1998, and worked as registrar in the Yorkshire Uveitis Register in UK. He is presently consultant ocular inflammation and immunology, Shroff Eye Centre, New Delhi. His research interests includes infectious uveitis, UWF angiography in pediatric and uveo-retinal disorders. He is co-coordinator for PG program of DNB and executive member of the Uveitis Society of India. And apart from this, he is a wonderful human being and a great friend.
Thank you very much.
I would like to welcome you in this webinar. And as you have already listened to Sir, it was a wonderful session, and we will definitely go on to the discussion and questions.
Yeah, there are some questions, Dr. Shishir.
So, sir, thank you very much for coming from Chandigarh and being with us in the AIOS studio, and wonderful to hear very close to you, though we have in the past, but every time there is something to learn from you. So, sir, we have some questions. I think we should address them before we have our own discussion. So, one of the questions that has been posed to you is what is the basis to start anti-tubercular treatment? It's a one-line question, but I think you will have lots to say on the decision making when you have a patient with a choroidal tubercle or retinal vasculitis, which you think could either be probably or presumed to be tubercular. So, what guides you to?
So, it's a very challenging question, because every time we face this dilemma, should we or should we not start anti-tubercular treatment in a given patient who comes to us with some inflammation of the eye and either the quantiferon or a Montus test positive. And there is a dilemma, is it the quantiferon positivity enough to start that patient on anti-TB treatment? So, I would say no, we do not treat the test, we treat the patient. So, one of the basic principles in management of patients with uveitis is that we don't treat any test. In fact, if you heard me carefully, I did not mention any test, and my whole emphasis was on clinical exam. I did give a demonstration of some of the signs that we see in patients, and over we have from literature and from our own publications certain clinical signs which are highly suggestive of tubercular etiology, like when we say occlusive retinal vasculitis with or without associated choroiditis lesions. Now, if you see that there is a choroiditis lesion, and I showed you an example, and occlusive vasculitis in a patient, and in him you do a test and quantiferon test or a skin test is positive, I know that this patient has possible tubercular etiology. If in this particular patient, if like I gave you the two examples, if I have access to biopsy, I can't obviously do a choroidal biopsy in this patient. If I did a lymph node biopsy and we could demonstrate a caseating granuloma due to tuberculosis with or without presence of AFB, again it corroborates, strengthens my diagnosis. It still is a probable case of tubercular retinal vasculitis. But if in this particular patient, if I did a Witti's tap or a aqueous tap and I can demonstrate the presence of MTB DNA from the ocular fluids, then I know I am dealing with what we call as a confirmed case of ocular tuberculosis. So you could start your treatment based on only the clinical signs without any other test or with only one test positive, where it would be like I don't have a CT chest or X-ray chest doesn't reveal presence of pulmonary TB, only skin test is positive, okay, or a Montus test is positive and there is an ocular sign. I want to start now this patient on treatment based on what we call a possible case of tubercular retinal vasculitis. But if I could demonstrate from extraocular site the presence of TB bug, I would call it a probable we are dealing with a case of tubercular retinal vasculitis. But if I could demonstrate the presence of TB, we can't demonstrate AFB. I haven't seen a patient of tubercular retinal vasculitis where I could demonstrate AFB. For that you would need to do enucleation of the eye to demonstrate the presence, which people used to do almost 100 years ago. They would remove the eye thinking that this eye TB is responsible for pulmonary tuberculosis. We have gone a long way from there. We have come a long way from there. Okay, so we have possible, probable or confirmed. For making a confirmed tuberculosis which will satisfy anybody, we can't demonstrate AFB, but even if we can demonstrate the presence of DNA from the ocular fluids, to me it's a confirmed case. So these would be my guidelines for starting anti-tubercular treatment. Based on ocular signs we investigate. So one sign I have shown you, retinal tubercular, the retinal vasculitis with or without associated choroiditis. The other is multifocal serpaginoid choroiditis or serpiginous like choroiditis, which I again showed you an example. Thirdly, if you saw a choroidal granuloma, and I showed you some of the features of choroidal granuloma, or in the anterior segment, if I saw broad posterior synecdoche. Why broad posterior synecdoche? Because this is such an insidious onset that patient is asymptomatic, it's a painless inflammation of the eye, so it leads to the broad posterior synecdoche. If associated with mutton fat KPs and a skin test is positive for tuberculosis, for me this patient is definitely a case of TB uveitis and I would give him anti-TB drugs.
Also, Dr. Geetubani asked the same question, what is your cutoff for Montu test? So
it's not my cutoff, this is given by WHO criteria. 10 millimeter is positive, 10 and above is positive. Patients who are on immunosuppressive drugs, on corticosteroids, or patients with HIV infection, 5 millimeter, if they are showing a reaction 5 and above is a positive test.
Absolutely. We go to the next question. Dr. Suman Sahu, she asked, do we need to give valcyclovir tablet in ARN or PERN due to HIV, or an injection of intravitreal ganciclovir will do for a situation where you have acute retinal necrosis in a patient with immunosuppression?
Yeah, I think we could give, if the patient has HIV infection and you see a case of acute retinal necrosis, okay, by and large it would be VZV, okay, and we would like to treat them not only with acyclovir, which is given intravenously, 8 hourly, for induction for the next 5 days, followed by oral acyclovir or valcyclovir, but some of these patients may be resistant to acyclovir, and in those situations we have given intravitreal ganciclovir, and they have responded positively to that drug.
So what would be your basic investigations for before starting corticosteroids?
Basic, when you want to start a patient on, you have to make sure the patient is not diabetic, patient is not hypertensive, okay, patient has normal counts, is not suffering from obvious any infections. So general routine investigations we like to do to rule out any systemic disease at this point of time, okay. Yeah.
And even I would add, osteoporosis in elderly, because
we have not been doing routinely any bone scans for these patients who are put on corticosteroids, because we want to prevent osteoporosis by limiting the high dose therapy to a very short duration, and quickly all those patients who required long term corticosteroid therapy have to be on immunosuppressive therapy, whether we like it or not. So we would like to restrict within 4 weeks, we like to come back within 4 to 6 weeks, we like to come to maintenance dose. Anything above 8 milligram per day of corticosteroids is extremely likely to lead to avascular necrosis of the neck of the femur, as well as fractures, and so we'd not like to have a patient on more than 8 milligram of corticosteroids or prednisolone.
Dr. Purva's similar question, how early will you start steroids in TB patients? Because earlier we used to start anti-tubercular first, and now we are changing with the understanding of paradoxical disease that you want to give.
I think I would start simultaneously, if not before, because if you understand the pathology of tubercular granuloma, it's basically immune mediated response to the presence of the MTB bugs in the tissues. So we want to prevent, because this immune reaction in terms of the eye would lead to devastation in the, as far as vision is concerned. So we like to contain that inflammatory response or immune response to the presence of TB bugs, and cover that adequate or normal dose or full dose of corticosteroids.
Because when we first understood that TB is causing uveitis, we were giving ATT and having a lot of scarring. Then the pendulum swung to the other side. We started giving steroids before starting ATT, and now I think it's come to balance with starting both together.
Yeah, and I may like to add here that corticosteroids are typically combined with anti-TB drugs for extrapulmonary tuberculosis when it's affecting the CNS or tubercular meningitis, when it is affecting the lungs causing pleural effusion, as well as when it's causing pericardial effusions, because if we did not do, it will lead to a paradoxical reaction, would be fatal for the patient. And in the same line, we like to prevent damage due to paradoxical reaction by giving full dose of corticosteroid, which is 1 milligram per kg, not exceeding 60 milligram on any given day.
This is absolutely paradoxical to the way we would think, as anterior segment surgeons,
Yeah.
that you start steroids with ATT.
Yeah, that's what.
Sir, there has been a bit of a controversy on the role of quantiferon TB. I had a patient who told me it's not going to be done because it has been banned. So what is your
Quantiferon TB Gold has not been banned. I think it's a misinformation.
Yes.
There is, so far the restriction is on serology. Quantiferon is exactly the same in vitro test, that what we do is the tuberculous skin test, which is an in vivo test. We are testing the ability of sensitized T cells to produce interferon gamma when they are challenged with the TB antigen. In tuberculin skin test, we are injecting a crude tuberculin, which is a crude extract proteins from the TB bugs. In quantiferon we are using highly specific ESAT6 or CFP10. These are the antigens which are specific to MTB. Okay, so it's probably a little more specific than tuberculin skin test, but there we are getting that overnight incubation in a test tube, the production of interferon gamma in response to these proteins by sensitized T cells which are from the blood of the patient, and in vivo we are seeing the same reaction by way of the induration in response to the tuberculin injection. There is no difference as far as the pathology is concerned or pathogenesis is concerned.
So, definitely Dr. Vinod Kumar's question. So, we can continue to do quantiferon and it has its own role in,
Yes.
in
Yes.
the management of patients with uveitis.
There is another question which can be just taken up now, that after completing the ATT, would you still?
So, Dr. Ramak Kumar asks, after completing a course of ATT, is it necessary to repeat MEN2 or quantiferon TB to know the treatment response?
No, I think I think somewhere we are paying a lot of emphasis on laboratory tests. I haven't received any clinical question as yet, and I'm not a laboratory man. I don't order after the patient is healed. If I'm satisfied as a clinician that the pathology is healed, which incidentally almost 85% of our patients, both in our reported experience as well as what has now been reported in the collaborative ocular tuberculosis group studies, they also find exactly the 85% response rate. So is some of the reports coming from UK and Europe, where they are seeing almost like 85% response rate by way of non-recurrence of inflammation subsequent to the treatment with anti-TB drugs, which indicates fair enough, because many a times our treatment for 6 months we give it with the belief that it will eliminate all the TB bugs. It may not. There is no way to know if there are TB bugs still living in our tissues. They can lie there dormant forever for next 100 years and you will never know. Okay, so it's not needed to keep testing again and again to see if those bugs have disappeared.
It's not an indicator of response to treatment.
No, it's not an indicator.
So that's why there's no need.
You look for clinical response. You know.
Okay, Dr. CD asks, what's the how do you differentiate clinically between occlusive and non-occlusive vasculitis? So now you have a clinical question here.
Yeah. So I showed that the fluorescent angiography is the most elegant test and the very good test, very sensitive test to look at the perfusion of the retinal capillaries, and that is what we do here. So clinically there is no way, once there is a perivascular infiltrates, there is no way you can tell except that there are a lot of hemorrhages that this vessel is perfusing or not. You don't see the blood flow. The only way you are going to see the blood flow is by doing either the fluorescent angiography, and these days of course you can do an OCT angiography, which is a non-invasive tool. You know, we still have the limitation of doing OCT angiography in the peripheral lesions where, you know, the majority of the retinal vascular inflammation and TB is occurring in the retinal periphery, where we still are not able to reach with OCT angiography. So in future we will, certainly.
I think, sir, you are inundated with questions on TB, which I think is absolutely understandable. Yeah. So
we would like to take one more question. Dr. Sangwan is watching you,
Yeah.
sir.
Okay.
And he's very happy to
Hello,
watch
Dr.
you.
Sangwan.
It's a very inspiring talk, he says. And he says if patient of presumed ocular tuberculosis is on IMT and ATT, after clinical response, which one would you stop first?
Yeah, I think it's a very
last
good
year
question
very
coming from Dr. Sangwan. Yeah, you know, in my experience, I have needed to give immunosuppressive therapy
longer
to almost 3 to 4% of nearly 1,000 patients of tuberculosis in the eye that I have treated. And what you stop first is, I think, the steroids, because steroids are the major culprit. So whenever you have you start immunosuppressive therapy, you want to phase out the corticosteroids first, any day, and then the immunosuppressive therapy.
But there will be a subset of patients, I think, whom he is targeting, who would still require treatment after the course of anti-tubercular treatment is over.
I think very few patients would require anti-TB, the continuation of corticosteroids after completing antitubercular therapy. Okay, so typically people would give anti-TB drugs for 6 to 9 months, but we have to keep in mind, I like to give it for at least 12 months. And in the initial patients who did extremely well with us, they were the ones in 90s who were treated with 18 months of therapy. Okay, they were doing exceptionally well. The basic principle is that patients when have TB in hypoxic sites, and eye is a hypoxic site, although it is located in choroid, which is high flow organ or tissue, but it's a hypoxic site. The granulomas are hypoxic. In the hypoxic environment, the MTB loves to thrive, loves to live, okay, and loves to hibernate and go into dormancy. Okay. Now, the anti-TB drugs would work only when they are dividing, like in the lungs. They are in a oxygen-rich environment, and that's how they are producing so much catastrophe in the lungs. Okay. And there they are dividing, and they will be taken care of with 6 months therapy. But in extrapulmonary sites, these would require much longer therapy. Of course, there is no way to know whether you have eliminated all the bugs from all the sites. It's presumption, it's at best a clinical guess.
Right. I think we'll take some other topics and then come back to TB. Shrikant, Dr. Shrikant is asking, toxoplasmic retinitis, non-responsive to Bactrim DS. What's your experience with intravitreal clindamycin?
Wow, intravitreal clindamycin is now the standard of care. Remember those days when we in 80s, 90s, we used to treat our toxoplasma retinochoroiditis with oral clindamycin. And you know, pyrimethamine is a toxic drug, it's not even available freely. Okay, and so is the sulfadiazine, and where is this available? Okay, and there's issues with sensitizing with sulfa drugs, you know. So we used oral clindamycin, and we were typically giving them 50 grams of clindamycin, enough to kill them with pseudomembranous colitis, with Clostridium difficile infections. Okay, now we treat with intravitreal clindamycin 1 milligram once a week, and at best they may need just 2 injections. So 2 milligram versus 50 grams, where is the comparison?
Only thing is you can combine it with dexamethasone.
Yeah, we combine with dexamethasone
intraocularly, but never with IVTA.
Not with IVTA, never.
Because
never.
The toxoplasmic endophthalmitis has been reported, just like what sir had shown earlier.
Yes.
The patient
we have to be very.
So there's another question on toxoplasma, sir. Dr. Jayant Thikka wants to know, should we start steroid and antimicrobial simultaneously or after 1 to 2 days of antimicrobial therapy?
You know, I am wary of giving steroids in the same setting, though it's recommended. The standard of care is intravitreal clindamycin with intravitreal dexamethasone in the same setting and can be given. I would be happy if it were my eye, I would like to get clindamycin today and dexamethasone maybe tomorrow. So I like to delay it and follow the old dictum, you know, in management of these patients.
Dr. Chavir is asking, what is the role of peripheral PRP, pan-retinal photocoagulation, in cases of field occlusive vasculitis?
If you develop neovascularization, sure enough.
But if there's no
that's
NV?
a standard of therapy. If prophylactic laser photocoagulation, well, if you feel comfortable doing it, fine. I have nothing against doing a prophylactic laser photocoagulation, because many of these patients would develop neovascularization elsewhere. You might not be clinically as efficient to detect early neovascularization, and the patient may just present only with vitreous hemorrhage. So we can avoid that by doing a prophylactic laser photocoagulation.
So if towards the end of your treatment, would you consider ultrawide field angiography for seeing?
I think that's a standard of, I didn't go into the details of the fluorescent angiography. Ultrawide field, if it's available, is a very good tool to assess patients with retinal vasculitis, not for its activity and active inflammation, but also for extent of capillary non-perfusion and to demarcate areas which should be treated with laser photocoagulation. We never treat healthy retina, perfused retina with laser photocoagulation.
Dr. Purva asks a little bit different question. You didn't cover scleritis, but the question is, sarcoid scleritis, are they more sensitive to immunosuppressants than steroids?
Sarcoid long-term treatment, I didn't go into the management, I was just focusing on evaluation. how we reach the diagnosis. But if it is a sarcoidosis, these patients require a long-term immunosuppression. Typically, we use methotrexate. Again, in childbearing age group or people given to men given to alcohol intake, we avoid methotrexate, but it will be a drug of choice in patients who have scleritis because of any reason, and sarcoid is one of them. Yeah, sure.
Dr. Amit Palkar is asking a challenging question. Would you do an FNAB in subretinal abscess to confirm TB, or I think the question implies that you would give a treatment without having a histopathological diagnosis?
I would look for, you see, I would look for extraocular sites for biopsy, and I have shown that in 2 patients that we accessed the lymph nodes which are easily accessible, maybe the cervical lymph nodes, maybe if they are more than a centimeter size, you could access by EBUS and other techniques. The pulmonologist would do that, and the surgeons would do the cervical lymph nodes. So I won't do it. But as far as the eye is concerned, well, I would, in any patient where I am not able to make a clinical diagnosis and I have to go in, I would choose a microinstitutional vitreous surgery, and these days we have choice of 23, 25, 27 gauge, which are, and that's where we published our results a couple of years ago, where we have shown that this is not only very safe and effective, there is hardly any complication. In fact, the inflammation starts improving the next day, and the vision starts improving, and they maintain that vision for as long as 1 year. So remove the vitreous gel and subject that to a number of tests, be the cytopathology, be the PCRs, and be the cultures, rather than, I do not like to puncture unless the retina to go underneath and remove tissue, unless I am suspecting masquerade. Here I am talking of primary vitreoretinal lymphoma, which any day, if I have a suspicion, I will puncture the retina, go in and aspirate out the cellular material for cytopathology, which we have done a number of times. But I have burnt my fingers puncturing an obvious TB granuloma, and the patient led to complications. Because what you are doing, and this is reported by our friend Jyoti Biswas from Chennai in early 90s, where they attempted to aspirate this sepsis, and in the process they ended up having the TB bugs migrate into the vitreous cavity and proliferate there and led to panophthalmitis, and eventually the eye had to be removed. So I don't want to access subretinal abscess with surgery.
But it's very interesting, sometimes you can have a lesion which you think is a masquerade and it turns out to be tubercular. So that
it could, I would take a call on that, because it could certainly, but now there is so many telltale evidences of both masquerade as well as TB granulomas, then we can tell the difference, so I'll hold my hand on that.
So a lot of our senior stalwarts are watching, like Dr. Bharti Lamangya ma'am, Dr. Kalpana Suresh, Dr. Abhijit Chabra.
Wow.
All of them are watching, and we have one question from one of our senior residents who left, Dr. Raghav Ravani from RP Center. Line of treatment for serpiginous like choroiditis. Does steroid alone help in these cases?
If you ask me honestly, if I did not find evidence of tuberculosis in these patients, which we eventually find in all, I would treat with corticosteroids and wait for evidence. If you treated any patient without evidence of tuberculosis with anti-TB drugs and they develop hepatotoxicity or liver cirrhosis or something like that, it will be very hard to explain why did you start anti-TB drugs. So you must have some evidence. And many of these patients actually of serpiginous like choroiditis or multifocal serpiginous choroiditis, they do not have evidence of TB. And in these patients, we have treated them on steroids. We believe that this is immune mediated response. They respond very well, but recurrences are so common, and when they recur, and in our experience which we reported in 2015 in ophthalmology, almost 75% of these eyes which were treated on, and they were just about 12 patients who were treated exclusively on corticosteroids, 75% of them, 9 of them, they recurred again with serpiginous like choroiditis, and when we tested them, they were found to be TB positive now. Okay, compared to almost like 90 plus, I don't exactly remember the number of patients, there were 94 or 95 patients who were treated on anti-TB and corticosteroids, and they did show almost 15% showed paradoxical reaction, but there were no recurrences. Paradoxical reaction is seen immediately in the following weeks after you initiate the treatment, but eventually these are the patients who would do not recur, and we followed these patients for several years and they didn't recur. This number of paradoxical reaction, I must clarify, was 15% when we were using the conventional fundus photography. With ultra wide field photography, the peripheral lesions also recurred, and our number has now jumped to 40%. If you ask me today, this is the major challenge we face in the world today is number one, can we predict paradoxical reaction? What is it due to, and how do we deal with it? So we are still struggling to deal with it, and we deal with it with enhancing the dose of corticosteroids only. I hope I
Yes, absolutely, sir. So Dr. Vinay Kumar asks, can there be coexisting VKH and sarcoidosis? You had shown some lesions which look similar, and patient had a typical pinpoint lesion with septae on OCT.
I think we should not be getting confused. Like if I have to tell the difference between sarcoid is typically seen in older individuals, VKH is young females 20s to 30s. Okay, bilateral, they would have some kind of headache or some kind of tinnitus, some kind of prodrome before the onset. They will not have any respiratory symptoms or breathlessness or weakness or some such thing which will be seen in sarcoid patients. When you look at the fundus, you would have multifocal serous detachment, disc edema, and when you do OCT or do ultrasonography, you find a diffuse thickening of the choroid, which is maximum in the peripapillary choroid. That's where the melanocytes are maximum located, against which this immune reaction is taking place, and it tapers towards the periphery where there is the least number of melanocytes. So diffuse thickening is one feature which you can detect on ultrasonography, whereas there is no diffuse thickening, there are localized granulomas which could be a single granuloma or there could be a multifocal, which I showed you in an example, where you could pick them up. If you did an ICG, it will be able to tell you the difference, where in ICG you would see a multifocal small granulomas in VKH disease which remain hyposenescent or isosenescent, unlike sarcoid granulomas, depending upon whether they are involving the full thickness. If they are full thickness of the choroid, they will remain the hyposenescent throughout the ICG study. Okay, and if they are partial thickness, they will become isosenescent. So they lose their hyposenescence. So you can tell the difference between these granulomas. I don't think I've been confused with sarcoid and VKH.
Not you, sir. It was from one of the people trying to.
If you do a thorough clinical exam, I think you would be able to. Yeah.
Sir, Dr. Shavir is asking again, how long immunomodulator and steroid should be continued in patients with VKH if the disease is stable? And that's the question. She also wants to ask another question, clindamycin only in cases of fovea threatening lesions or as the first line of treatment and all, whether it's a macula is involved or not involved in toxoplasmosis. So these are two questions.
So first question is how long we give immunosuppressive therapy in patients with VKH disease. Well, steroids we give only the maintenance dose, and maintenance dose could be as low as 5 milligram either every other day, or 2.5 milligram every other day, with immunosuppressive dose which can be brought down to, say, if we are giving an azathioprine, to as low as 25 milligram a day. This therapy has to maintain for at least 2 years in the first go. Earlier people used to say give them for 6 months. Remember, these are autoimmune diseases. You can't wish them away. You are hoping that you will lose the memory T cells so long the memory T cells are present in your body, in your system, they will reactivate. I have tried to stop immunosuppressive therapy at 3 years, 4 years, within a matter of few months, these patients come back with the recurrences. The more recurrences they have, the more chronic they become, the more resistant to treatment they become. So in the first very attack, I would like to maintain them. Only we need to do is the follow-up on liver functions and WBCs, the count, the blood counts. If we do it every 6 to 8 weeks, I think that should give a great safety margin to the use of.
Whenever you start immunosuppressives, do you also take some medicine person or physician or
You know,
internist?
we always collaborate. The best physician to collaborate on these is rheumatologist, because they are every day they are using immunosuppressive therapy for autoimmune diseases, and also they are using now biological therapy very extensively. So if we need to use biologicals or immunosuppressive therapy, we always like to consult. To be very sure, we need to consult with a rheumatologist, in my view. Yeah.
So, sir, clindamycin intravitreally, now we have in
If
atypical
it's a vision
toxoplasma.
threatening, sure enough, I would give. And if I had in peripheral toxoplasma retinochoroiditis lesion and there is causing a lot of inflammation and debris in the vitreous, I would like to again give intravitreal clindamycin. But if it is not, and the patient is sure to come back for a follow-up, I would perhaps maybe wait for a while.
And then you can wean them off and keep them on once weekly or twice weekly.
Visit.
No,
Visit.
back trim or something as a long-term treatment.
Long-term treatment,
in
I think
recurrent
if
cases.
we have 3 or more recurrences every year, we reserve the use of tablet of Bactrim given every 4th day as a prophylaxis therapy. But that's for high-risk patients who are known to have recurrences. In patients who are HIV positive, they are routinely given the Bactrim because many of these patients will die of CNS toxoplasmosis. So these patients are given as a prophylaxis on a routine basis.
Sir, questions are still coming in, but I think we'll use our website to answer those questions, which we have not been able to address,
I think
and we can
we've
put
had
them
a
up,
very, very
and
interactive audience.
whom we
who
need to
are-
thank
yeah,
for
who
being
are
there.
pouring in questions.
Well, thank you very much for giving me this opportunity
Yes,
to
and
interact with
you
the audience
highlighted and you
with
answered each one of them so patiently.
Not just
And,
patiently, but also everything is absolutely crystal clear in your mind. So whatever you
Thank
say,
you,
I mean,
Rajesh. Thank you
I
very
mean,
much. I think
anyone and everyone
I
will
thoroughly
understand.
enjoyed this session, and
so we would
I'm-
like to thank you, sir, for
Thank
being
you.
here with us.
thank you.
And also Shishir, thanks a ton for
Thanks for being
again.
calling me and having me here in this wonderful session. Right, yes, thank you.
So the proceedings of this would be available on the website soon, and we hope that you would continue to interact like this in the future webinars also. A very interactive audience and a great crowd there. Thank you so much for being with us. Thank you.
Thank you. Thank you.